So a very warm good evening to one and all present here today. I'm really honored to invite you for the World Pre-Eclampsia Webinar Series in association with National IRIA Preventive Radiology and Samrakshan Committees. I would like to invite Dr. Vijay Matthew, Secretary IRIA Kerala, also Committee Member Samrakshan, to take over.
Thank you. Thank you, Soumya. This is the fourth day of the Preeclampsia webinar series, which was inaugurated on Sunday on the World Preeclampsia Day, May 22nd, by Dr. Evelyn Ho, the President of the Asia-Oceanian Society of Radiology. After that, on Monday and Tuesday, we had two sessions, which was inaugurated by the presidents of
AOSR.
No, that's okay. President of Gujarat State Chapter, Professor Dr. Deepak Mehta, and the President of Punjab State Chapter, Dr. Mukesh Gupta, and the Secretary of Punjab State Chapter, Dr. Amandeep Singh. And along with them, the President of Kerala State Chapter, Dr. Gomadi Subramanian, is also present. We had the three academic sessions are over. Today, on the fourth academic session, on behalf of Samrakshan National IRIA Preventive Radiology Committee, today we are having a very important discussion, very important academic session that is about the screening of preeclampsia and FGR. That is a core concept, core theme of Samrakshan. And that talk will be given to you by the National Coordinator of Samrakshan, Dr. Shilpa Satarkar. She is from Aurangabad, Maharashtra, and is doing phenomenal work as the National Coordinator and has been an integral part of the Samrakshan movement ever since it was started. To inaugurate this session, I have with me the President and Secretary of the largest state chapter of IRIA, that is the Maharashtra State Branch, MSBIRIA. The President of Maharashtra State Branch, Dr. Balakrishna Kitture sir, and the Secretary of MSBIRIA, the Maharashtra State Branch, Dr. Sandeep Pansare, are here with us. Welcome, sir. We are honored to have your presence here. And let me invite Dr. Balakrishna Kitture sir. He is from Ichalkurinji, near Kolhapur in Maharashtra. And Maharashtra State Branch of IRIA is one of the most dynamic state branches for a long time, and they have been doing a lot of activities on all fronts, including the sports activities. They've got the RPL, that is Radiology's Premier League, a cricket league. Yes. that is conducted successfully for so many years, involving all the city chapters. And they are on the forefront of social activities. In fact, the Raksha movement started in Maharashtra, and also they are very much on the academic front, and even in fetal radiology and imaging, they have got they created a course called Basic Course in Fetal Radiology and Genetics, BCFRG, which is in the 6th year. And I'm fortunate to be a part of that movement when it was mooted in Indian College of Radiology as the fetal radiology subspecialty head. I played a crucial role in getting recognition for that particular course. So with that introduction, let me invite the President of the MSBIRIA, that is the Maharashtra State Branch of Indian Radiological and Imaging Association, one of the most dynamic and largest branches of IRIA, Dr. Balakrishna Kitture sir, to address this August gathering. Over to you, sir.
Thank you, Dr. Rijo and Shilpa Madam and team Samrakshan. Thank you for inviting me on this occasion of the week we are celebrating or educating the people on a Samrakshan. I have seen this team working for last 3 years, and the idea and all information was given by Shilpa to me. And I know the importance of preventive radiology campaign run by Samrakshan for last 2 to 3 days, and will be for more 2-3 days will be there. And these people are working very hard, this team Samrakshans, and we know this will go on and to the smallest level and smallest city, this type of training, and this will help definitely to the society. I'm practicing obstetric radiology, though not very dedicatedly, but slowly I am reducing this obstetric practice because of other load, but I know the importance of to diagnose the fetus at a risk, like anomaly scan and a genetic scan. Fetal loss in third trimester is preventable, and early diagnosis is very important. And for that, every radiologist should have in-depth knowledge in the Doppler, use of Doppler in the pregnancy to prevent the fetal losses. Unfortunately, the many radiologists are not aware, and the job comes to this summer action team to educate all radiologists. And as a part of IRIA and president of MSBRIA, we are decided to take this with the help of Shilpa and your team to the chapter level. And the MSBRI is conducting the sessions on BCFRG every year. This is the course recognized by ICRI. And already Shilpa is a part of BCFRG. What I suggest Shilpa to reserve one session only on summer action, so that every year 100 radiologists will be educated and get the in-depth knowledge of this, so that the society is benefited. We all must contribute to the academic social drive run by Summer Action. I really appreciate the efforts taken by the team Summer Action. Thank you.
Thank you. Thank you. That was Dr. Balakrishna Ketture, the president of Maharashtra State Branch of Indian Radiological and Imaging Association, who has very positively assured us that the Samrakshan will be made an integral part of their prestigious BCFRG course that has been running successfully in Maharashtra, with several candidates from all over India being delegates and participants in that. So that is a very reassuring statement, very positive statement. Thank you very much, sir. Let me invite the secretary of MSBIRA, the dynamic and young Dr. Sandeep Pansare, who is from Pimpri Chinchwad near Pune. And let me tell you, the leaders of MSBIRA are from the different parts of Maharashtra, which is not just limited to the metros, but the leadership of MSBIRA are very, very keen on the Samrakshan, preventive radiology, and things that can change, the things that really matter in their practice. So they are very positive on this, and I'm extremely thankful to the leadership of MSBIRA for positively taking forward Samrakshan and preventive radiology. Let me invite the secretary of MSBIRA, Dr. Sandeep Pansare, to address the audience today. Over to you, Dr. Sandeep.
Yes. Thank you, Riju sir, for inviting us, and thank you, Shilpa, madam, and the entire Samrakshan team. I just want to highlight the one program that is the most needed thing was, this is the unique program that Samrakshan, which is involving the practicing radiologist, and that also most of the from rural areas or tehsil places where most of our population is crowded. So rather than having some data or papers published from colleges or any other limited data, this is the unique program where we are gathering data from different strata of the people, or because ours is a different culture in India. So we are going to have a very huge data where we can really lead by front by creating our own standards, own parameters. And I want that more and more radiologists should participate in this program. And as we discussed earlier, we should move on with the move for multidisciplinary approach, where not only we are practicing, but also we should involve gynecologists and pediatricians for the success of this program. I once again thank the team Samrakshan, and my best wishes are always with the team. And I'm very proud that I have participated as a delegate and as a contributor to the Samrakshan program. Thank you so much.
Thank you, Dr. Sandeep. Dr. Sandeep has been submitting forms from Pimpri Chinchwad on the Samrakshan Multicentric Research Project, and has been a great supporter of Samrakshan. And Sandeep has rightly recognized the need to have interactive sessions, the reach out programs, which is one of the 7-star programs of Samrakshan, to have the reach out programs in with obstetricians and obstetricians and neonatologists or pediatricians to make them aware about the preeclampsia and FGR screening programs, and also involve them in the management for better outcomes. Thank you, Dr. Sandeep Pensare, and we
Thank
are
you.
very happy. The Samrakshan team and the preventive radiology team is very, very happy for these reassuring words from the
Yes, sir.
President and Secretary of Maharashtra State
Pleasure,
Branch
sir.
of IRIA. Thank you very much.
Thank you, sir.
Now, let us move on to the academic session of the day. The first talk will be given by the National Coordinator of Samrakshan, Dr. Dr. Shilpa Satarkar. She will be talking about the core theme of Samrakshan, the preeclampsia and FGR screening, and how to do it. So this is what is going to be. This is a very, very important. This is a technical package. This is the main learning that you need to understand from Samrakshan and to apply it in your practice. Shilpa is the national coordinator for 2022 for Samrakshan and has been doing phenomenally well for this program. Let me invite Dr. Shilpa Satarkar to start the academic session. Over to you, Shilpa.
Thank you very much, Rijo sir, for this kind words of introduction. And I'm really happy today Dr. Kitture and Dr. Sandeep Pansare are here. In fact, in BCFRG course, in the first module, we are having a 35 minutes talk. I only take the talk on preeclampsia screening. And every time I tell you, because everybody know about nuchal translucency scanning, all anomalies and other thing everybody know. But preeclampsia screening is such a new thing for each and everyone. So the session always go for 45 to 50 minutes. So many questions are there. And I'm really proud to say that till now in 6 modules, we have trained almost 400 radiologists from Maharashtra. And though people are not filling the forms, but at least more than 50% of them have started doing the preeclampsia screening because I get a lot of queries and questions. And now we are forming the Maharashtra group also, as I told you. Next month we will be having a short meeting with them, and then we'll go ahead with it. So I'll just start with the session and share my screen. Good evening all. Welcome all the attendees. So the very, very important topic, what is preeclampsia and FGR screening and how to do and interpret it. So under Samrakshan, we are having two major programs. First is the preeclampsia and FGR screening, and second is the integration of the color Doppler in the growth scans. So with both of this, our aim is to reduce the perinatal mortality of India. And how we are going to reduce this? Because the major cause of perinatal mortality in India are some hypertensive disorders, which I'll be discussing in my some coming slides. And this we can identify, we can screen the same way we screen for NT, we can screen for preeclampsia and FGR. We can start certain treatment with them, and we can get amazing results with this screening and the treatment protocol. And we can absolutely save life of lot of our mothers and children. So how we will go, how we are going to do that, we'll just discuss. So this report of the National Health Survey of 4th NH4, it says that the perinatal mortality is 36 per 1,000 and the neonatal mortality is 30 per 1,000. And major cause are the hypertensive disorders of pregnancy, and major causes of these high mortality are the low birth weight as well as the prematurity caused because of the pregnancy-induced hypertension or related disorders. And not only it is affecting the fetuses, but in the world, it is a very, very important cause of the maternal mortality. Nearly 50 to 60,000 mothers lose their life each year. So if you break down it to in minutes, so every 10 minutes somewhere in the world, one mother is dying because of hypertensive disorders of the pregnancy. So this is such a devastating disorder. So we have to do something for this disorder, and our country is very, very in a very high prevalent zone for this preeclampsia and FGR. So if you see, in developed world countries in the Western world, the prevalence is around 1 to 5%, while in our country, it is reported from 8 to 25%. Some hilly areas in the north and northeast, they are nearly having 25, means 25 ladies of every 100 ladies are having preeclampsia, and eclampsia is reported in them. So much is this is the average data is around 8 to 10%. Sorry. And you can see the area where the prevalence of preeclampsia is very high, we get very severe adverse outcomes. And major cause of the perinatal mortality are the perinatal asphyxia and prematurity, both of which are majority of the times because of the preeclampsia and related disorder. So also we have to think that it's in India nearly 30 million births occur every year. So 8 to 10% women are at the risk of preeclampsia. So nearly 3 million women are at the risk of preeclampsia. And out of the 30 million childbirths each year in India, 3.5 million are premature and 35 to 45% are fetal growth restricted. So 10 to 14 million children are fetal growth restricted. While if you see that congenital anomaly, the rate of congenital anomaly is around 6 lakh, that is 0.6 million, 0.6 million and 10 to 14 million. So we are not allowed to miss a single case of congenital anomaly. But at the same time, are we allowed to miss a single case of preeclampsia? So if 10 to 14 million of our babies are having growth restriction, or mothers are having preeclampsia, the complications are so many high. So are we doing really anything for preeclampsia or FGR screening? So that is what Samrakshan has come out with. And we all are requested, all radiologists are requested to start with the preeclampsia screening basically. So if you see that the incidence of Down syndrome is 1 per 800 to 1000, for which we do the nuchal translucency screening at the nuchal translucency scan, for which the scan takes around maybe 25 to 30 minutes. For incidence of congenital anomaly, which is 20 to 27 per 1000, we spend nearly half hour. But while the incidence of hypertensive disorder, it is around 80 to 100 per 1000. And here we need to spend only 50 seconds to take the uterine artery PI. Rest of the things our staff is going to do. So this disorder, if you see that it is a preventable thing, you can spend very less time. So we request all the radiologists to start with this. See, screening for Downs, screening for congenital anomaly is absolutely indicated. But at the same time, we have to start with the screening for preeclampsia and the FGR, because that is the major issue in our country right now. We are losing mothers, we are losing children for that. And that is a preventable thing. Down syndrome, you cannot prevent anything. Congenital anomalies, yeah, some non-lethal things you may operate and you may prevent the, you may give the good quality life to the fetuses. But these disorders, hypertensive disorders, they are preventable in 60 to 80% of the cases. We have so good results that the lives are saved of mother, children, and all this is going to affect with a very good result in the perinatal mortality of India, and that is the aim of Samrakshan. So these hypertensive disorders of preeclampsia, they have very short-term complications as well as the long-term complications. So as I told you, it's a leading cause of maternal death, and the most worst thing about it that there is no premonitory symptom. Today you do ultrasound, next day the mother may have severe disorder and she may rapidly deteriorate. And in mother, it may lead to eclampsia, HELP, abruption, then pulmonary edema, hepatic and renal involvement. While in the fetus, it will lead to growth restriction, prematurity, NICU stay, and even intrauterine fetal death. And not only these are the long-term, short-term complications. Long-term in the mother, it increases it doubles the lifetime risk for the cardiovascular disease, hypertension, IHDs, stroke, and even death from the cardiovascular disease can occur in mother who was having preeclampsia. While the children who are exposed to preeclampsia before birth, there is a double risk of cerebral palsy. And when these children become young adults, they have very high incidence of blood pressure, increased risk of cardiovascular disease, high BMI, increased risk of diabetes. And believe me, all these complications can definitely be prevented by developing an effective method of predicting preeclampsia, which is nothing but the preeclampsia screening. So basically, what is screening? So screening basically is a strategy where we have to look for an yet unrecognized or an incipient condition by evaluating certain risk marker. As in our nuchal translucency scan, we try to find out that if the fetus is having chromosomal abnormality. What are the markers we use? We use NT, NB, DV, and TV. So with the help of these 4 markers, we are going to screen for aneuploidy screening in the first trimester. Similarly, for preeclampsia screening, we also have some certain simple markers. What are the markers we will be seeing? But it's a very simple thing, and we should start this for the good of our country. And when we are doing a screening, we have to remember that screening is basically it's not a diagnostic test, and there are chances of a false positive and false negative cases, and therefore like you have to understand that there can be a false positive and false negative while we are doing the screening for preeclampsia, or for that matter any screening. And the major purpose for the preeclampsia screening is to detect the incipient preeclampsia cases and to prevent its progression. And how we are going to prevent it? By a very timely and effective care, which is nothing but early institution of aspirin, which is going to definitely improve the perinatal outcome in nearly 60 to 80% of the cases. So just by giving the aspirin in a screen positive patient, we are having a very good result. So before going to that, let's understand what is preeclampsia screening. So basically, it's a multi-system syndrome developing during the second half of the pregnancy. The symptoms appear in the second half, and we have to detect that, yes, we have to predict that this will happen in the second half. And it is characterized basically by hypertension, proteinuria, and maternal organ dysfunction. And in a chronic hypertensive patient, when there is proteinuria or maternal organ dysfunction, which develop after 20 weeks, then we say that there is preeclampsia superimposed on the chronic hypertension. And when the systolic BP is more than 140 and diastolic is more than 90, or if there is proteinuria of more than 300 milligrams, or there are two readings of at least 2+ on the dipstick, or there is maternal organ dysfunction in the form of altered LFTs, KFTs, there can be headache, blurring of vision, or certain hematological things like decreased platelet. All this will point out towards the preeclampsia. And the preeclampsia can be divided as early onset preeclampsia, which occurs before 30 to 34 weeks, and preterm preeclampsia, which occurs before 37 weeks, and then term preeclampsia, which occurs after 37 weeks. And it can also be divided by mild and severe preeclampsia, but the this early and preterm preeclampsia is a proper and worldwide used thing. So before going to the disease, if we understand the pathogenesis, the treatment, how it acts, it becomes understanding becomes very easy. So as we know that the uterine artery divides into multiple branches, and the final is the spiral arteries, which are present in the decidua. So what happens in pregnancy? The trophoblasts, they invade these spiral arteries, they destroy the muscle layer and the endothelium of the spiral arteries, and then they divide these into big channels. So these channels then supply adequate blood to the placenta. But what happens in preeclampsia? Basically, this trophoblastation or the remodeling of the spiral arteries does not occur, and instead of becoming so big channels, the spiral artery remains as it is in the decidua as well as in the myometrium, and therefore the blood going to the placenta is reduced, and therefore placenta experiences placental hypoxia. And this hypoxia, because of defective remodeling, this releases certain toxins in the body of the mother, which are called the pro-inflammatory proteins, and these toxins then damage the endothelium of the blood vessels, leading to hypertension. And also similarly, when the endothelium and the end organs are damaged, like the liver and kidney, then we get altered LFTs and the proteinuria in the kidneys. And at the same time, this hypoxia very badly affects the fetus, which we are aiming in the basically in the screening. There is fetal growth restriction, there is hypoxia and all other things. And the final treatment for preeclampsia, if the mother is deteriorating, that is the delivery at any stage, because we have to save the mother. So basically, to understand that preeclampsia is a two-stage disease. First is the asymptomatic stage, which occur before 20 weeks, and it is the defective placentation. And we have to identify this stage because treatment given in this stage is highly effective. So for that, we need to do the screening in the preeclampsia. In the second stage, which is a symptomatic stage, which occurs after 20 weeks, where the lady develops hypertension and or other complications. And the very important thing we need to understand is that the preeclampsia and FGR are both consequences of defective placentation and uteroplacental insufficiency, and both share the same spectrum. So placentation is a two-stage process. First wave occurs, which starts at 8 weeks and end by the 14 weeks. And what happens here? This is the trophoblast. They invade the spiral artery mainly in the decidua in the first half of this cycle, that is between 8 to 14 weeks. And in the second half, the decidua invade the spiral artery in the myometrium, and then whole of the spiral artery, including the myometrium and the decidua, it becomes big channels. So this first wave is absolutely important. If we detect that in this first wave, we are going to, this patient is going to, we can predict that she is going to having preeclampsia, then we can start treatment in this patient. And therefore, we have to do the preeclampsia screening in all the ANC population before 14 weeks to identify the high-risk patient and start with aspirin in them. And aspirin helps in a very amazing way to increase the placental number of blood vessels in the placenta, as well as the branching and newer blood vessel formation in the placenta all occurs because of this, and thereby it reduces the risk of hypertensive disorder and its complication. And taking into account the inverted pyramid of the antenatal care, we have to detect the high risk cases in the very early phase, and then we have to keep this under surveillance, and we have to go ahead to till term to give a very good result. So in the first trimester scan, as we all do the nuclear translucency scanning, where we look for aneuploidy screening, and then we assess for the structural defects. Screening for preeclampsia and FGR is absolutely important, and that will be just looking at how we are going to go with them. So as in our anti-scan, we combine the a priori risk with multiple markers and give a patient-specific risk for the risk for the aneuploidy or trisomy 21. Similarly, in this FMF model, which we are using right now, because we don't have our own data to create our own guidelines and models, we are right now using the FMF method, and therefore we are requesting all radiologists to participate in the Samrakshan, do the sonography in the Samrakshan protocol, start filling the Samrakshan form so that we get our own data, and therefore we can form our own guidelines for our own population, because our population is definitely different from the Caucasian and the American or the other world population. So for that, we need everybody to join Samrakshan. So what we are doing here in according to the FMF model is that we are combining the a priori risk, which is calculated by the maternal characteristics and the medical history, with the results of biophysical and biochemical measurements, and then we are giving the patient-specific risk for preeclampsia. So what are the markers or the parameters under the screening? There are certain maternal characteristics, mean arterial blood pressure of the mother, uterine artery Doppler is to be done by the radiologist, and then biochemistry like the PAPE and the PLGF is done. Under Samrakshan at present, because of the non-availability of the biochemical markers at remote places or in certain small areas, and also considering the affordability of the patients, right now we are using only these 3 parameters. But if your patient is affordable and if the facilities are available, you can go for the use of the biochemical markers for doing the preeclampsia screening. So screening for this preeclampsia and FGR is a 5-step approach under Samrakshan. So the first step is taking the maternal history. Second step is measurement of the mean arterial blood pressure. Third step is to do the uterine artery PI at 11 to 14 week scan. And fourth step is to calculate the patient-specific risk for PE and FGR from the FMF calculator, which is freely available on net. And fifth, the very important step is to filling the Samrakshan forms to gather our own data, to have our own guidelines and our own things for our own population. So if you go on net and go to the Fetal Medicine Foundation site, on the home page, you can see this calculator. Just click on this. On left side, you will see these calculators for various risks. You have to select this 11 to 14 weeks calculator, and then you have to fill all this data in this, where you have to say that if it's a singleton or a twin pregnancy, what is the CRL and what was the date of examination. And then you have to ask the mother for the history. So what we are going to do, and this history, once you train your staff, right now, majority of our who are doing the Samrakshan form, they have trained their staff, and shortly the video for training staff will be uploaded on the IRIA site. So just you can ask your staff to go through that video. You can see that video and train your staff. 2 to 3 sessions sitting with them, they can do very well the filling of forms and everything. It is that easy. So in the maternal characteristics, we are going to ask for the mother's age, height, weight, because all this affect the calculation of the risk. Also the race of the, we are South Asians, we are having genetically high in prevalence in our area. Then the pregnancies associated with assisted reproduction technique have high incidence of preeclampsia. Then we have to ask about the history of comorbidities like chronic hypertension or diabetes mellitus, SLE, or APLA syndrome. Then parity, because nullipara have a very high incidence of preeclampsia again. Then if in the previous pregnancy was that lady having preeclampsia, yes, it was a history like that, then again in this pregnancy there are around 8 to 10% chances that she will have preeclampsia, and a family history of preeclampsia, either mother or either a sister, then again this lady is going to a higher risk of having preeclampsia. So the history taking is absolutely important, which the staff can take for you very easily. And once you take the history on this FMF site, you have to just put yes, no, and thing, and then automatically the history goes in the data of the calculator. Like, so what the NICE and the ACOG guideline tell us that if you use only maternal characteristics and medical history to screen for preeclampsia, nearly 51% cases of the early onset preeclampsia and 43% cases of the preterm preeclampsia can be detected at the false positive rate of 10%. So for the time being, let us forget this FPR. So 51% cases can be detected. So high chances that nearly 49 cases are yet to be detected. So to increase the detection rate, the mean arterial pressure was used. So what is this mean arterial pressure? So basically, first I'll tell you how it is to be taken. So we have to make the lady sit comfortably on a couch. Her arm should be supported. We have to use 2 sphygmomanometers, and we have to put the 2 sphygmomanometers on the arms simultaneously. She should be comfortable. Her leg should be uncrossed. The cuff size basically should be appropriate. It should not be too big or it should not be too small. And then while taking the, when we take the measurements, the lady should be quiet and she should be comfortable, and she should be like, she should not be anxious. So, and when we put this, the cuff size and everything, and then we have to take the blood pressure simultaneously in both the arms. And so we have to take a series of 2 recordings at 5 minutes interval. Sorry for this typing mistake. The interval between 2 readings should be 5 minutes, and minimum of 2 readings should be taken. Basically, what is mean arterial pressure? So it is nothing but the diastolic pressure plus 1/3 of the pulse pressure. Pulse pressure means systolic minus the diastolic pressure. So every time we need not go and calculate on our calculators or anything. We can just put this in the FMF calculator. In the biophysical measurement here, you have to, when you click over this, you can get measurements of the left and right arm, systolic, diastolic, and just you have to put all your readings, which we have taken twice, and then the system automatically calculates the MAP for you. So when this MAP is calculated, with these maternal characteristics and MAP, now the detection rate of early onset preeclampsia is 74 and that of the preterm is 63. So still we have to increase the detection rate, because any screening test should have a very high detection rate. So for that, then the uterine artery Doppler was used. So how to take the uterine artery Doppler and how to calculate the PI? So basically, transabdominal and transvaginal both can be used, but preferred is transabdominal way. We have to identify the uterine artery, and the sample gate then should be of 2 millimeters with angle of insolation of less than that. These are the things which we use in all Dopplers, so it is not that tough. We have to identify the uterine artery by peak systolic velocity, which should always be more than 60 centimeters per second. And then we have to calculate the PI from each side, and then do the calculate the mean PI. So how we are going to calculate, how we are going to identify the uterine artery? First, you need to identify the cervix and then the internal os, and then identifying the internal os, you have to sweep the transducer slightly to right and left, and then we have to identify the uterine artery here at the level of internal os, and we have to keep the sample gate here, and then we have to take the reading. Similarly, on the transvaginal scan, we have to identify the internal os, and then again we need to move the transducer and identify the uterine artery and take the sample volume there and do the Doppler reading. So the uterine artery is identified by its typical waveform of this high velocity flow and this notch. So basically, this notch is seen in nearly 50% of normal women also. And secondly, it's a subjective marker, means I may feel a notch, you may not feel a notch. So again, it is a subjective marker with low specificity, and therefore we need not mention notch in the report. What is most important for us is to identify the PI, measure the PI of the uterine artery, and the mean PI of more than 95th percentile is abnormal. To know how much is the PI, there are certain nomograms available on the net, or then on the FMF calculator side, or even in the Fetal Medicine Barcelona site, you can go and then you can identify the how much is the PI and what is the percentile also. Now, we have to remember certain facts about this PI. Actually, in the first trimester, between 11 to 13 weeks scan, 2.35 is the 95th percentile, but a blanket cutoff should never be used. We have to use a week-specific cutoff, which the calculator calculates, the FMF calculator calculates for you automatically. And then the mean PI on TVS is always high, and a cutoff of 3.5% for CRL up to 65 is used. And therefore, if you are doing the PI on TVS scan, you have to use the comparative charts for TVS and not the general T8 charts. And a very important thing we need to understand is that a unilaterally increased PI does not appear to be associated with high risk of preeclampsia if the mean PI is within normal limits. Anytime we get the report that if one uterine artery PI is more than 95, then the patient is labeled as screen positive, but this is not true. You have to take the mean PI, and the mean PI is the thing which is important, not a single-sided. And now many of our radiologists, they don't go for the total screening, the combined screening. They give only this one parameter of uterine artery PI in the reports. So this meta-analysis said that if you are using uterine artery as a sole solitary marker, then you can identify only 48 cases of preeclampsia, 48% cases of early preeclampsia, and 40% cases of FGR. So see, you are missing a lot of cases. And therefore, this paper says that given the low sensitivity of the uterine artery PI, clinicians and mothers need to be aware of the possibility of not identifying women who may develop early onset preeclampsia later in the pregnancy. So why to miss this 52% cases just for a simple thing? To train your staff, they will do. Anyway, you are going to take the uterine artery PI. So after training your staff, and they can very well calculate the combined risk for you, and just you have to include that in your report and sign the report. It is as simple as that. So again, we request you to go for the combined screening and not going only for the solitary uterine artery Doppler as the marker to be used. So when you in this FMF calculator, again you have to just put the right and the left uterine artery PI. The mean PI is calculated for you. Now under Samrakshan, because as I tell you the reason, we are not including the biochemical measurements. So you have to just click no here. But if your patients are affordable and they want to do it, you can calculate that, and you have to put this data here. So after that, you have to just click on this calculate risk, and the calculator gives the automatic risk for you. So in this calculator, you can see two risks come. One is the preeclampsia risk from history alone, and then whatever markers you are going to use, the history comes. So we are using three markers: the history, MAP, and uterine artery PI. So along with this, it is giving you the risk. And not only that, this calculator also gives you the recommendation. So now this patient is the risk is 1 in 106. So for South Asians and our Indian population, and even in the Samrakshan, we are using the cutoff of 1 in 150. Same is being used by the FMF also, because we want to have high prevalence. We want to bring maximum number of the ladies under like surveillance and detect maximum cases. The cutoff used is 1 in 150. And when this cutoff comes to a high risk, then a recommendation is given that on this basis, the basis of aspirin trial, you have to start this woman with aspirin 150 milligram to be started right now till 36 weeks. And so that she will have a very good results of about 90% for preeclampsia before 37 weeks and 60% for preterm preeclampsia. So everything is given here, and this you can communicate with your gynecologist, and then the patient should be started on the aspirin. And similarly, we can go on this fetal growth restriction prediction of risk, and all the parameters used here are almost same. Here, only thing we need to add is if she's a Paris woman, then we have to give the weight of the previous fetus and the interval between the two pregnancies, because the interval, if it is less than 12 or more than more than 7 years or like that, then the chances of having FGR and preeclampsia again increases. And again, the similar way we have to just click on this calculate risk and we get the risk for the fetal growth restriction. Again, for fetal growth restriction, we are using the cutoff of 1 in 150. So now with the help of maternal characteristics, MAP and the uterine artery PI, the detection rate has now increased to around 80% for the preterm, for the early onset, and 70% from the preterm preeclampsia. So again, now to increase the detection rate, biochemical markers were used. So we are not using them, but just we must know what are the biochemical markers. So the placental growth factor and the pregnancy associated plasma protein, these are the two factors which play a very important role in the placental growth and development. So basically this PLGF molecule, it is a key molecule for the angiogenesis and the vasculogenesis. So what is angiogenesis? Vasculogenesis? Vasculogenesis means increasing the number of the blood vessels, and angiogenesis means increasing the branches of the blood vessels. So the blood supply to the placenta should be increased, and that is the main aim. So these placental growth factors helps in the same thing. And this PAPA also plays a very important role in this. And in preeclampsia, the PLGF values are low. And in like preeclampsia, PLGF is low, as well as it is low in the certain trisomies like 21, 18, and 13 also. And this serum SFLT1, this is the placental anti-angiogenic factor. So what happens? This SFLT1, it binds to the PLGF receptors and it prevents the action of the PLGF on the receptors, and therefore again it prevents the angiogenesis and decreases the number of the blood vessels, and therefore definitely it means in preeclampsia the SFLT1 level is going to be increased, and this increased level precedes the development of the disease by about 5 weeks, so that we can predict that early also. So basically, in biochemical thing, there is a imbalance between this angiogenesis and the endothelial damage. The SFLT1 increases and the PLGF decreases. So now, with the help of this MAP, maternal characteristic, MAP, uterine artery PI, and the biochemical markers, the detection rate goes to around 96% for early onset and nearly 77% for the preterm preeclampsia. And then these are various studies which give the various rates, like detection rates for various false positive percentiles. Right? So if we think with the 3 markers, we are going to have a nearly 80% detection rate, which we are using under Samrakshan. So this first trimester screening algorithm, as we have seen, it gives us a very personalized risk for the estimating the screening, and these risks can be given to all the pregnant ladies, including para also. And with certainty of nearly 97 to 99.8%, we can say that the preeclampsia will not occur in the screen negative women. So this much is the usefulness. So we have to start giving the preeclampsia and the FGR. And this trial, ASPRI trial, has shown that when you start with 150 milligram of aspirin at night to a high-risk woman who is screen positive, till the 36 weeks, then it reduces the risk of preeclampsia by 80% in early onset and nearly 60% in the preterm preeclampsia. So see, the effects are so good just by starting the aspirin tablets. And this this trial is absolutely helpful. And it also says that the low dose aspirin, which started in the first trimester in these screen positive women, it causes a significant reduction in FGR, severity of preeclampsia, severity of PIH, and preterm birth. So it has multidimensional effect in all the complications which could be associated with the hypertensive disorders, and they can be prevented by this aspirin, which we need to start in the screen positive women. And it not only helps this, but aspirin also delays the development of preeclampsia. Means if the woman is going to have preeclampsia, say at 34 weeks or 32 weeks, then if we are started with aspirin, that may be delayed to around say 38, 39 weeks. So at least the baby gets that much time for a adequate growth, and then we can have a very proper outcome. So low dose aspirin means we have to use 150 milligrams, which is recommended by the ASPRI trial. 75 milligrams is not that much useful. There are resistant cases with 75 milligram, nearly 30% resistance with 75 milligram, and 5 to 10% resistance with 150 milligram. So 150 milligram is recommended. It should be given at night. Compliance is extremely important. Your gynecologist may tell your patient she has to take, but you can also just put a word that she has to take every night regularly for the good of the baby. So definitely any mother will do anything for her baby in the womb. So you have just need to put such words. And at times what happens, the patient comes for sonography and she goes to the gynecologist, say after a month or maybe some days later also, or even at times what happens, 16, 18 weeks, the patient comes to us for the first time. So should we start this aspirin in the patients who are detected to be screen positive at 16 to 18 weeks? Yes, we can start with them, because at least in 10% of the patient, it will be useful to reduce the maternal and the fetal morbidity. So it will affect the second phase of the second wave of the placentation, which occurs from 14 to up to 18, 19 weeks also. So it can be useful in these patients also. So now, how the Indian scenario will change if we all start the preeclampsia and the FGR screening? We are seeing that the total pregnancies in India is around 30 million. So our prevalence rate is around 8 to 10%. So 24, considering 8% prevalence risk, 24 lakhs are at the risk of having preeclampsia. Now, if we do the preeclampsia screening in all patients, then we can detect around 20 lakh patients of having high risk by this maternal characteristics, MAP, uterine artery, PI, with these three parameters. And now, if we start aspirin in these patients, so 80%, 60 to 80% of these ladies, means 12 to 16 lakh of these ladies, as well as 12 to 16 lakh of the fetuses in their womb, they will be having absolutely good effect, and the complications or the long-term, short-term complications of preeclampsia will be prevented. So we are definitely going to have a very, very good effect. We can save life of nearly 12 to 16 lakh mothers and the same number of children. So 24 to 32 lakh lives will be changed if we just do this preeclampsia screening and start aspirin in the screen positive woman. And so if you just think about this number, you will definitely start giving the preeclampsia and FGR screening in the first trimester. And how to do that and everything is available on the IRIA website under the Samrakshan, Samrakshan column. Samrakshan, basically, as I told you, it is the project of IRIA to reduce the perinatal mortality. So what it integrates the fetal imaging and the childbirth planning. We have to, do the preeclampsia and FGR screening in the first trimester, and in the third trimester, we have to integrate the color Doppler. No growth scan is complete without the color Doppler, because color Doppler help us, as I told you, nearly 10 to 14 million of our fetuses are growth restricted. So how we are going to identify this growth restricted fetus in the third trimester? So in the third trimester, with the help of color Doppler, we can differentiate between the small for gestation and the fetal growth restricted babies. And with the help of color Doppler, again, we can categorize the growth restricted babies. We can put them under surveillance, we can monitor them, and then at a proper place and a proper time, we can ask the gynecologist to deliver this, and therefore we can reduce the perinatal mortality. So these two things are the main aim of Samrakshan, the first trimester preeclampsia and FGR screening, and integrating the color Doppler in all the growth scans. So for that, Samrakshan is working since last 3 years, and in last 2 days discussions, we have seen how it is being helpful to our own country, because why we are having diseases which are specific to our area. So we need to focus on them. We need to find out our own ways to treat them, our own ways to monitor, or at least identify them. So for that, we need a very India-specific data. In pertaining to preeclampsia, we need the trimester-specific data. We need to know the childbirth outcome. So all this is what we are doing under Samrakshan forms. So therefore, we need to collect our own data in huge number from various areas, various parts of India. We request all radiologists to start filling the Samrakshan form, so that we can have our own database and we can have our own guidelines. So just again to summarize, with the help of maternal history, mean arterial pressure, and uterine artery PI, we can detect around 80% cases. And including the serum markers, the detection rate can go up to 90%. And out of all this, what as a radiologist you have to do is to only measure the uterine artery PI. MAP history taking, once you train your staff, they can do for you. They can go on the FMF site and calculate the risk also for you. So the take home message is that screening is must in the first trimester for preeclampsia and FGR. If you are giving only the uterine artery PI, then you will miss 52% of the cases. In our scenario, maternal characteristics, MAP, and the uterine artery PI can detect around 80% of preeclampsia cases. And in your reporting format, there should be the values of percentile values of the uterine artery PI, then the patient-specific preeclampsia and the FGR risk. And also, you should be able to communicate with the patient and your gynecologist regarding the 150 milligram aspirin and its compliance. Thank you very much for your patient listening.
Thank you, Dr. Shilpa Satarkar, the National Coordinator of Samrakshan Program of IRIA 2022. So for the very elaborate and nice description about the technical package of Samrakshan, especially the essentially two components, the preeclampsia and FGR screening at 11 to 14 weeks, and then the assessment for fetal growth restriction, especially in the third trimester and the second trimester, for understanding whether there is an early fetal growth restriction or a late fetal growth restriction, and to grade them accordingly for the timing and mode of delivery and for the best outcomes possible. So this is the Samrakshan package. Many people are confused. What exactly is Samrakshan doing? Samrakshan is a categorical package that we have brought in to integrate fetal growth parameters and the feto-maternal environment assessment into your pregnancy scans, which are currently focused only on structural anomalies, only on chromosomal anomalies. But we want to give another dimension to your pregnancy scans. That is, it has to be integrated with fetal growth assessment, because fetal growth abnormalities can cause more perinatal deaths. It has to integrate feto-maternal assessment, maternal environment assessment, because maternal environment or feto-maternal environment abnormalities can cause maternal deaths as well as fetal abnormality, fetal growth abnormalities. So this is the point that we want to highlight in Samrakshan, and we have conceived this program and has come out with a package from the existing data that is accepted. But we have applied it in the Indian circumstances in various parts of our country with a multicentric study for the last 2 years, and has brought in a team from various parts of from the different states of India, who has passionately worked on it and submitted the forms, has been talking on it, and Shilpa Satarkar has been in the forefront of the movement for the last 3 to 4 years. Thank you, Shilpa, for that wonderful lecture. That the technical package.
I also made it. I have made certain 3-4 cases for discussion. So should we discuss that if time permits, or?
Lalit sir, do you have your cases or?
Yes, I am ready.
Lalit sir, if he's having his cases, then it's okay. Yeah, we'll go with Lalit sir.
Let Lalit sir show his cases, and maybe in this week, Shilpa, if you can join us, maybe tomorrow or so, we can share your cases there too. Okay. Right, because I'm not sure because we wanted to finish this program within 1.5 hours. I don't want to take it beyond 10:30.
Okay. When we give the answer, there's some questions also. They will answer them at the end of the session.
Yeah, right. So thank you, Shilpa, once again, and wish you all the best to take Samrakshan forward to all the 718 districts in India, which is what our dream is. So we have we have to reach out to radiologists, obstetricians, and neonatologists in all the 718 districts in India, and help them to implement the Samrakshan protocol so that lots and lots of our mothers and babies can be saved. So the second phase of Samrakshan is now moving into the micro focus on preterm births, prematurity. How can we avoid that? How can we reduce that? On low birth weights, it's another area. Even in so-called developed places in our country, so-called places where the maternal mortality and perinatal mortality indices are less, low birth weights are still a problem. I can tell you Kerala is an example for that. Kerala's infant mortality, Kerala's neonatal mortality, perinatal mortality, maternal mortality is comparable to the Western standards of 30. But Kerala's low birth weights are more. This samrakshan can play a pivotal role even in Kerala to reduce the number of low birth weight babies in Kerala. So it has got a role for all over India, for all the districts of India. So we want to reach out to 718 districts. Radiologists in 718 districts has to be the ambassadors of the Samrakshan and Preventive Radiology Program of the Indian Radiological and Imaging Association. Now let us move on to a case discussion by another pivotal person of Samrakshan who created his own models in integrating with multiple levels of healthcare, multiple stakeholders in healthcare in a district of Guna in Madhya Pradesh. And he has licensed with the district administration, and there the district collector, Mr. Frank Nobel, has taken considerable interest in this project and has integrated this Samrakshan protocols, and they have launched a program called Baroza, and integrating 38 Anganwadi centers now catering to nearly 2 lakh population of Guna district. And the leader of that program, who's leading that program from the front, is Dr. Lalit Kishore Sharma, the social radiologist from Guna. Lalit sir, you may start your presentation. Can you share your screen, sir?
Yes. Good evening all. Is it visible and I am audible?
Yes, sir, you are visible and very much audible. And we are very happy to see you, sir.
Thank you very much. So I will be discussing a few cases based on all the Samrakshan parameters and my practical experience within 3 years. They are based on these, and they are the real cases, not from the books. So Samrakshan, as we discussed and told by the madam,
Sir, if the slides are not moving,
okay, no, they are moving. Okay. So Samrakshan vision and protocol, as screen protocols are told by the madam Shilpa Satarkar. It is by the first trimester screening for identifying the high risk patient for PE and FGR based on the FMM calculator guideline, and the high risk patient should be put on the LDA from the first trimester to 36 weeks or till the delivery happens, and based on the third trimester Doppler evaluation, which identifies the PE and FGR and management according to the Barcelona calculator, with the emphasis on the timely termination of pregnancy of untreatable conditions and optimal balance between the minimizing the fetal injury or death versus the risk of iatrogenic preterm delivery, with the awareness of the fact that leaving the FGR fetus to the delivery at term may lead to the perinatal morbidity and delayed effect like the cerebral palsy, with the core focus for preeclampsia and fetal growth restriction. Because the an important assumption in the as per the SEO guideline, the pregnancy dating has been carried out correctly, preferably in the first trimester by the ultrasound, and there are no fetal pathologies such as aneuploidy, congenital malformation or infection. It is very important to date the pregnancy because uncertain gestational age is the independent of the maternal characteristic and the cause of the low birth weight, which has got the 20 times infant mortality rate, prematurity and post maturity. And hypertensive disorder, PE and eclampsia are the causes which are dependent on the maternal characteristic. Not moving, I think. Okay. And as told by Dr. Rijo previously also, that we have to assess the growth on percentile basis after the first trimester dating has been done. We have to assess whether the fetus is small for gestational age or it is appropriate or it is larger for gestational. because these even the larger for gestational age fetus are at risk for diabetes and perinatal death. And we have to understand how the Samrakshan works with the protocol and with the aim. As the FGR patient, they are the main cause of the stillbirth cases in our country, mainly from the 43 to 60% cases, with the fact that overall stillbirth rate is 4.2 per 1000 birth, but only 2.4 in the non-SGF fetus, which increases to 9.7 in antenatally detected FGR cases to 19.8 per 1000 if they are not detected. And these are the different protocol for the delivery to occur, and how when the things happen P or FGR, then we can decide on these protocols. Now I will go for the, this is the IRA Samrakshan Bharosa program as told by the Dr. JournoMed. It is done on the name of Indian Radiological Association. I will discuss. He is Mr. Frank Novalet, our collector. He is MLA from Guna, and he is the Rotary President, and this is myself. I will just discuss about the few cases. First, I will just discuss about how the preeclampsia can cause the maternal death. This is the first case. She came to me first time as a private patient.
So
On
the slide has not moved, I think.
Okay, it is not visible. Okay.
Shilpa, is it visible for you?
No, sir.
No.
Okay. I will again share it. Okay. I think this something
Is this the same PPT, sir? PowerPoint?
Yes. I think it is visible now. Is it visible?
Now the thank you slide has come, sir.
Okay. Now, first slide.
First slide is okay, but not the cases that you are showing. I think the case.
Okay. I will come to the cases now. I think now it is visible.
No, so cases may be a different PowerPoint, not in this one. This has got only 5 slides, I saw.
This is visible now.
This is visible where your Bharosa project and IRA Samrakshan logo is there.
Yes, in that only they are the cases. This one, my report is visible.
No, sir.
Okay, then okay. I will just simply narrate it. Okay, this is the one patient. Because I prepared it like this, it was visible in my screen. I saw one patient on the 13th of February 20, and because of her high BMI and the hypertensive history in the previous, I advised her to go for the FTS preeclampsia screening. And on the dating, she was 10-week pregnancy, so I asked her to come on the means first trimester screening. I am really sorry. Why it is not.
Sir, can we do one thing?
Yes.
Can we have those presentation tomorrow, and so that
Yes.
Shilpa can share her cases?
Yes.
Yeah.
Because
Shilpa, can you share
not.
your cases, and then because it may not communicate well without that PowerPoint presentation.
Without that.
Yeah.
I am really sorry. I am really
no
sorry.
issue, sir. So we will have it tomorrow. Unmute, Shiv. Unmute.
Okay. So is it visible?
Yes, very much. You can start.
Okay. She's a case, she's a patient who comes at 12 week 5 days with a CRL of 70.2 millimeter. I did her scan, NT and everything was normal. The first trimester, everything was normal. Like NT, NB, DB, TR was normal. The anomalies, the early anomaly scan, it was also okay. And then I took the right and the left uterine artery PI. So the average uterine artery PI is now 1.94, it is 77 percentile. So now, should I label this? So majority of radiologists, they just look at the uterine artery PI and they say that it is 77 percentile. So cutoff is more than 95 percentile. So should I use this? It is not more than 90 percentile. So I'll pass that she is screen negative using only a single marker as uterine artery PI. But now if I give you the her history, if I give you details like the maternal characteristics, she's 26 years, primary, height 150 centimeters, weight 68.2 kgs. And then if I give you her blood pressure, MAP, which is 89, so MAP is slightly on a higher side. And when I go to the FMF calculator and calculate the risk, this is the preeclampsia risk and this is the FGR risk. So she is definitely a screen positive case, and then she should be started with aspirin 150 milligrams. So if you go alone with the uterine artery PI, definitely this patient will miss her bus and she will not get aspirin, and then she will land in the complications of FGR and preeclampsia and FGR. So my request to each and everyone is that don't go alone, don't use the alone uterine artery PI as a marker. Go for a combined screening, at least with these biochemical maternal characteristics and the blood pressure and things, both of them together, it will detect nearly 80% of the cases. So do the combined screening. So again, this is the second case where she comes at 13 weeks, 3 days. Characteristics, you just look at the patient, 22 years primary, height 151, weight is 39.5 kg. Her MAP, her uterine artery PI, see, one uterine artery PI is 2.32, other is 1.06. So now it is 2.32 on one side. So are we going to label that yes, she is screen positive because the uterine artery PI of one side is very much high? No, we are not going to say that. We have to take the uterine average PI, and the average PI is 1.69, which is 64 percentile. And then when we take the MAP, it is around 62. So it is nearly towards the normal side. But when you go to the FMF calculate and calculate the risk, the P risk is normal, but her FGR risk is 91. So she is screen positive for FGR. What could be the reason of she being screen positive? Just look at her weight. So her weight is around just 40 kg. So the mothers who are low birth weight have a very high chance of having the FGR babies. And unfortunately, in spite of giving the risk of FGR risk of 91, she was not started with aspirin. And now when she comes to me in the second trimester, she did a scan, it wasn't at my place only. So here you can see her AC is, though it is not less than 5%, it is definitely slightly on the lower side. And when she comes to me at 34 weeks, 4 days, 5 days, you just look, her AC is 250, that is nearly 29 weeks, which is corresponding to 29 weeks, it is less than 1 percentile. Her EFW at this gestation is 1701, which is corresponding to 30 weeks 5 days. So at 34 to 35 weeks, her blood fat should be around, EFW should be around 2.3 to 2.4 kg. So definitely she is a case of now FGR. So if she would have been started with aspirin, then probably all this could have been avoided in her case. Now this is a primary with 62 kg weight. Her MAP is on the higher side, it is 92. Her LMP, GA by LMP and GA by USG are corresponding. Her average uterine artery PI is 77 percentile. The risk for preeclampsia is 87 and for FGR it is 99. That means she is screen positive. So according to the Samrakshan and the FMF recommendations, we have to start her with 150 milligram aspirin daily at night till 36 weeks. And we have to communicate to the lady that she has to take that every night for the good of her baby. So in her 150 milligram aspirin was started. And when she comes in the second trimester, you can see that her AC is around 36 percentile, EFW is around 34 percentile, and the average of uterine PI is nearly 91 percentile. So she is taking aspirin. So these are, you can say like, okay. So when again she comes at 30 weeks, 6 days, now her AC is 6.8 percentile, EFW is around 7.8 percentile. And her uterine artery PI is 91 percentile. So the uterine PI has not crossed the 95th percentile. So it is, though it's higher limit of normal, it is still in the normal range. But now she is 6.8 AC and 7.8 percentile of EFW. That means she comes under SGA. So how to differentiate between small for gestation and FGR? So if the birth weight is between 3 to 10 percentile with normal Doppler, she is SGA. If the birth weight is between 3 to 10 percentile, AC or the EFW is between 3 to 10 percentile with abnormal Dopplers, then it is FGR. So this is the differentiation. So now she is she's under like SGA fetus, and according to the protocols of SGA, we ask her to come after 2 weeks, and the follow-up after 2 weeks was advised. She came directly after at 35 weeks, 5 days. So now you can see that her AC is 1.9 percentile, definitely less than 3 percentile. EFW is 6.2. Her uterine artery PI has now gone to more than 95th percentile. Other like umbilical, MCA, PI, CPR are normal. A BP is around 130 by 84. So now she is a case of late onset FGR. So in this case, you can see that because she was identified as screen positive, she was started with aspirin, she was taking it regularly, she was came for the gynec follow-up every time and for ultrasound. Though she came late, she came, and at least we could identify that yes, it was it was a late onset FGR, but because of aspirin, it was delayed. If we had not given her the proper identified her as FGR and screen positive of her FGR and P, and probably if she had not received the aspirin and she had not taken that properly, she would have landed in the early FGR. So here you can see at 37 weeks her LSAS was done, and a 2350 gram female child was delivered. So it was probably because of this treatment that she could go up to this stage. So thus aspirin delays the development of preeclampsia. Now this is one case where again you can see in the first trimester her PI, uterine artery PI were absolutely very high. Preeclampsia and FGR risk was again very high. She was recommended aspirin, but it was not started. Aspirin was absolutely not started. And when she came in the second trimester, her PI was more than 95th percentile, her AC was 11 percentile, and EFW was 5.9 percentile. So definitely it was on a lower, by definition, you can say that when EFW is less than this, she can be in stage 1 FGR. So a follow-up was recommended, but as usual, patient don't come at our place in spite of that repeatedly telling. So she was a case of like early onset FGR. And then on 29th week, she directly came. There you can see that her parameters are all the AC is 194, fetal weight is around 671, where it is expected at 29 weeks, it should be around somewhere between 1.2 kg plus minus 100 like. Her average uterine artery PI more than 95th percentile, MCA PI altered. Umbilical artery, here you can see that there is reversal of the end-diastolic flow. Then there was reversal of the aortic stomach flow, and the DVPI was more than DVPI was nearly 90 percentile. So she was a stage 2 FGR. Again, we ask her for a when it is in stage 2, you have to follow her twice bi-weekly. So we asked her to come for the follow-up as usual. In spite of offering her a free follow-up, she did not come. And then we again called her after say 5-6 days what was going on with her. She did not pick up the phone, and after 10 days when we called her again, she tell that yes, it was an IOD after few days after the sonography. So this was the case where in spite of she being screened positive, treatment was not started, and she landed ultimately in the severe FGR, and then she lost her baby. So this is the importance of having preeclampsia and the FGR screening. So these are the I think these are the cases. So yeah, I'll stop now.
Yeah. Thank you, Dr. Shilpa. Lalit sir.
Sorry, I will just prepare tomorrow.
Yeah, not so, sir. As part of this discussion, from the cases that Dr. Shilpa had shown, we have certain questions that has come up. One is from Jitendra Bensal has asked whether the cutoff for PE is 1 in 150 everywhere, or is it different? Shilpa, would you like to answer?
Yeah. So basically, the cutoff is 1 in 100 under FMF. Why? Because they have studied the Caucasian population, the Western population, where the rate incidence is very low. Their genetics makeup is very different. But in South Asians, Afro-Caribbeans, these people genetically have a very high incidence of preeclampsia, and for these populations, the cutoff under FMF is also 1 in 150, and also under Samrakshan we are using the cutoff of 1 in 150. Because of the high prevalence, we want to detect maximum number of cases, and therefore we are going to have this 1 in 150 cutoff.
Yeah.
And first pregnancy is also at the 2.5 times more risk.
Yeah. There was somebody had asked, they can't find IRIA Samrakshan website. I had answered there. You are, for all the details, you have to go to www.iria.org.in. Once again, www.iria.org.in. And in the main menu, you have to go to click on the main menu. You can see programs. And if you click on the programs, you will see Samrakshan and preventive radiology there. Click on the Samrakshan link. Then you will get an access to the introduction of the program, about the project, about the Samrakshan library. Lot of resources are there in the Samrakshan library, Samrakshan videos, Samrakshan publications. And IRA in the last general body meeting has also announced a Samrakshan National Samrakshan Award, which is Dr. Lily Sharma's contribution towards to promote the Samrakshan work all over India, that any IRA member who is working for this Samrakshan project all over the country on different on the 7-star program of Samrakshan are eligible for the National Samrakshan Award, which is 10,000 rupees cash prize and certificate and memento and a certificate. So that will be announced at the end during our national conference. So the details of the award also has been announced. My referring doctors don't mention mean arterial pressure. They only give systolic and diastolic. What I can do about it? I think that has already been Shilpa.
Yeah. We have to, don't depend on what your gynaec do. Bring 2 sphygmomanometers. You can order on Amazon tomorrow. They cost hardly 2,000 rupees. Just train one of your staff how to take the mean arterial pressure. I showed you. You have to just comfortably make the lady sit, make her arm rest at the level of her heart, put the appropriate size cuff, and take 2 readings at 5 minutes interval. That is the thing you have to put. You have to take the BP. Don't depend on your gynecologist. And it is the mean arterial. Even if the systolic and say if the one of the question again is that in the first case, what exactly was wrong to have the result as high risk? BP was almost normal. Yes, the BP was normal, but if you see, the mean arterial pressure was high. So mean arterial pressure is systolic BP plus 1/3 of systolic minus diastolic. So if a diastolic, say, is a slightly on the higher side, say if it is 110/78, then the mean is going to be high. And this mean arterial pressure is the main important thing, because under this calculator, that is the thing studied very widely, and therefore we are using the mean arterial pressure rather than the
I just want to highlight on this mean arterial pressure in our Samrakshan series. Samrakshan's form submissions, we are seeing very interesting data that is coming out from the mean arterial pressures from the Asian Indian population. And it is different from the FMF this thing also. For Indians, we are seeing that our mean arterial pressures are higher than the many of the other populations so that is, if it is high, that will significantly add on to the risk of preeclampsia. So that is a very important factor in India that we have to train our staff or take some positive measures to train our staff to take the mean arterial pressure. It's pretty easy. The electronic sphygmomanometers are available online. You can buy it online on Amazon. It costs you 1,500 each. Two of them you buy it, train your staff, and they will give you the measurement. You have to take twice, ask them to take it twice, and they will give you the systolic and diastolic measurement. And once that is entered into the online calculator, that the mean arterial pressure will be, you will get it. And as part, and the combined screening, it will give you the risk at the end of that calculation. So that will say you whether it is screen positive or screen negative. So it's time for us to be the real clinical radiologist who asks history, who takes BP, who takes blood pressure. Even though we can delegate it to our staff, the patient will be quite happy to somebody asking the history on this thing, and then taking a blood pressure in an ultrasound center. So all these things will add on to your image as a clinical radiologist. It's not just image interpreters. We have to change that image. And in the period of artificial intelligence, it is our communication with the patients and the touch of the patient. And all these things are going to be the important. The human component that has to be brought into our practice, that is all going to make a difference. And in the new era where artificial intelligence can play a significant role. But again, our natural intelligence has to use the artificial intelligence and to increase our productivity, and at the same time to bring in the clinical element and the clinical and the human touch to our practice. So are there any questions? I think many of the questions has been answered in the chat box by our own course directors and the Samrakshan core team members. I can see Dr. Neelam Jain answering many of the questions there. I can see Jitendra Bansal answering some of the questions there. Thanks to Dr. Neelam and Dr. Jitendra for answering those questions. And I think we have, it is almost 10:22. I think it is time to wind up this program. So it's 1 to 1 to 1:15. That is the duration that we expected when we start at 9 o'clock a program. So beyond that, and we are continuing with this series till Saturday, and tomorrow we will be having the chief guest from Bihar State, the President-elect Dr. Praveen Kumar, and the Central Council member of Bihar State Chapter of IRIA, Professor Dr. Prem Kumar, who is also the HOD of All India Institute of Medical Sciences, Patna. So though they will be the chief guest for our program, and tomorrow we will be discussing another aspect of Samrakshan with Dr. Sandhya Dhankar joining in on how to take the color Doppler measurements from different vessels. So Dr. Sandhya Dhankar is a national Samrakshan committee member and is a contributor to the Samrakshan program in a major way, and she's from Chandigarh. So I think it is time to wind up today's session. I wish to thank the presenters, Dr. Shilpa Satarkar, for that excellent presentations, and Dr. Lalit Sharma sir, the social radiologist from Guna, who has come out with his own model of Samrakshan, that is the Baroza model, Guna Baroza model. With the district administration, he is doing phenomenal work, and that is becoming a role model for the rest of the districts in the country to take Samrakshan in a big way forward. And I'm extremely thankful to the President and Secretary of the Maharashtra State Branch of IRA, Dr. Balakrishna Kitture, and Dr. Sandeep Pansare for gracing this occasion and become the chief and giving the address to the audience here today as chief guest, and assuring us that Maharashtra is going to take Samrakshan and preventive radiology in a big way. So thank you all the delegates, and also once again thank the MedPiper, JournoMed team, the technical team that has hosted the platform and assisted in arranging this program. And once again, thanks to the program coordinator, Dr. Ramesh Chennai from IRIA Kerala, and the whole team of IRIA Kerala who is supporting this program. The National IRA under the leadership of Dr. Pushparaj Patele, and Secretary who is also from Maharashtra, Dr. Sandeep Kautale. So they have been supportive in the whole in the project of Samrakshan and preventive radiology. So thank you all who have joined.